Okay, welcome back everyone for our second to last session of this ECHO series. My name is Sarah Rowan and I'm an infectious disease doctor at Denver Public Health, and I'll be facilitating today. This is a partnership between the National Emerging Special Pathogen Training and Education Center, NETEC, Denver Health, the Denver Prevention Training Center, and the Robert Wood Johnson Foundation and Project ECHO. So we are very happy to see everyone here this morning. We're going to be talking about COVID management, prevention, treatment in special populations, particularly those in congregate settings, and specifically long-term care facilities, incarcerated populations, and people experiencing homelessness. So for Victoria, do we need to do a tech check? Are we good?
I think we'll be okay without doing one, but if folks do want to put where they're calling in from in the chat box, that way we can give an idea to our presenters where everyone is.
Yeah. And as our presenters are speaking, since we have 3 different presentations today, it's going to be pretty full session. If you all can put your questions in the chat, I'm sure that we go back to them at the end of the presentations so that none of the questions are missed. We are all interactive. So we will be starting with Carrie Levy, who's the Palliative Care Section Chief and Director at the Denver Center of Innovation for Veteran-Centered and Value-Based Research at the Rocky Mountain Regional Veteran Affairs Medical Center. Dr. Levy is a professor of medicine at University of Colorado Division of Healthcare Policy and Research. And we also have Dr. Singh Palat, who will be co-presenting with Dr. Levy. Dr. Palat is with LTC Rehab Consultants and is an assistant clinical professor of medicine at the University of Colorado in the Division of Geriatrics. So Carrie and Singh will be covering long-term care facilities, and I will turn over the mic to them.
Great, thank you. Can you hear me okay?
Yes.
Great. So Singh and I are so thrilled to be here with you today. We've been steeped in this area for the duration of the pandemic, and hope that this brief presentation will be helpful as you think about this particular population. Singh and I are both geriatricians and have worked in long-term care facilities for quite some time. So we're very excited to have the opportunity to present to you. Next slide, please. So this is really just an epidemiology slide to give you a sense of what's happening in Colorado. So these are Colorado data, and you can see on the top graph, these are new cases by week and new deaths by week. So the orange lines are resident deaths and the blue lines are new resident cases. And you can see in June, we were kind of just had a stable and worrisome, we were always worried, resident caseload and deaths. And then we had a little blip at the end of August and got very worried about that, and then took a deep breath and said, oh good, we're doing all right. And then in October, sort of middle of October, things just took off. And the case counts have been increasing week by week, as you can see, and as you might expect, deaths as well. And then the 2 graphs at the bottom, on the left, you can see the case fatality rate by month per outbreak identified. And fortunately, that is going down. So whereas we're seeing that case rise, that caseload rise, fortunately, we are not seeing as many deaths as we were originally. And then you see the average outbreak length has also decreased since the beginning of the pandemic. So whereas it was very long, as in a couple of months, the outbreak length, it's now declined to less than a month. And Dr. Palat's going to present the next slide.
We were asked to discuss long-term care today, but I realized that there are various names for such a wide variety of residential care settings, and they can be confusing. This slide lists a variety of settings, roughly with the settings that can handle a higher clinical acuity towards the top of the list and less acuity towards the bottom. And I have spent the last decade of my career providing care in skilled nursing facility and long-term care, both of which are often located in the same building or the same nursing home. The long-term care will always have nurses on site 24 hours a day. The patients usually have the ability to have oxygen titrated, intravenous therapies, labs, and x-rays. And long-term care specifically means that the patients have been admitted to live in the facility rather than, say, be there just for a brief rehab stay. And often the nursing facility staff will develop relationships with the patients and their families that last for many years. So you can imagine how hard it is to lose large numbers of long-term care residents during an outbreak. And during the COVID-19 pandemic, the long-term care facilities have, out of necessity, had to step up. Across the country, Medicaid is the primary payer for most long-term care stays, making this a relatively low resource environment. And it can be tricky in situations like when a resident has COVID symptoms and they also have a roommate or roommates, or when isolation unit is required and the building just isn't physically set up for it. You can see in this picture how an isolation unit was created just by putting up a plastic sheet, and that's the unit. And early in the pandemic, this was interesting, during a patient transfer, a hospitalist asked me for the first time ever if my nursing facility has negative pressure rooms. And the answer was and is no. Most long-term care facilities are not equipped for reverse or negative pressure isolation. One thing I'll mention about PPE is that most of the nursing facilities are not equipped to provide fit testing for N95 masks. And so fit testing is either contracted out or just simply omitted. And all long-term care facilities now have rapid antigen testing on site, but the lower sensitivity of antigen testing has limited its widespread use. Thankfully, the state of Colorado, through the CDPHE, has kept PCR testing available both for diagnostic and surveillance purposes throughout long-term care. And the turnaround time has improved substantially in the past couple of months. Cohorting in long-term care facilities builds on the assumption that facilities have all been under lockdown with heavy restrictions of visitors ever since March of 2020. The COVID-19 isolation unit should be designated for patients who have confirmed COVID-19 or patients admitted from the hospital who are still on isolation. And the units are recommended to have a dedicated entrance and exit and dedicated staff where possible. The observation unit is a separate unit for quarantine of newly admitted patients from the hospital who were not diagnosed with COVID-19. It provides a 14-day period of observation to monitor for new COVID symptoms. And others who might reside on the observation unit are patients who leave the building routinely, such as people going in and out for chemotherapy or dialysis. And the suspected and exposed patients have been trickier to cohort, at least for me. When patients show symptoms consistent with COVID-19 and are waiting for test results, they're not eligible to go onto the COVID unit. And a person sharing the same room or unit as a patient suspected to have COVID-19 is likewise not eligible to move to the COVID unit. Usually, the symptomatic and exposed patients stay in their respective rooms until more data like test results are obtained. And often a curtain is just drawn between the roommates to create a slight barrier between those two people who are under investigation. And of course, there are the unaffected patients who have no symptoms at all or no known exposures, and they should make up the rest of the facility. Only residents with confirmed COVID-19 tests should be on the COVID unit. That's what I'm learning here in the pandemic. And otherwise, we risk introducing COVID into a previously uninfected person. To reduce transmission risk, those who require observation or isolation should not have indoor or outdoor visits. I'm going to turn this back to Carrie, who will walk us through the surveillance testing.
Great, thank you, Sing. So surveillance testing, of course, has been a prominent feature of congregate setting monitoring and making sure we know how to handle outbreaks. So the way that this has been designed in long-term care is based on a number of factors, but the main one is the county positivity rate. So if county positivity rate in the past week is less than 5%, then surveillance testing is done twice a month, but people are encouraged to perform it weekly if possible. And the type of testing used when county positivity rate is low is PCR testing. If the county positivity rate goes up between 5 and 10%, then surveillance testing is done once a week. And because of the frequency at that point, we can introduce antigen testing or PCR. And then if the rate is high, so over 10%, surveillance occurs twice a week, either via antigen or via PCR. So loads of surveillance testing. I actually think this is going to be very helpful as we look at the vaccine and try to understand asymptomatic transmission after vaccination because of this frequent surveillance in long-term care. So that will be a hopefully positive outcome of the surveillance testing. Next slide. As far as return to work, this has been complicated for all of us, of course, in healthcare settings, and particularly in long-term care. As Singh mentioned, these are often low-resourced environments, so having all staff available is critical. And so we try to minimize the number of staff who are not working, but of course do it in a thoughtful way. And so if you start at the top of this algorithm, of course, if they have symptoms, they're restricted from work and get tested. If they have been exposed, this is where things get a little bit less clear. And we break it down into, was the exposure high risk? Were they exposed for a longer period of time to someone who was actively sick? Or was it a low risk exposure? For example, somebody, a friend of a friend who they spent time with was exposed to someone. So depending on the high risk or low risk exposure, then we go down the path. For high risk, it would be active monitoring and restriction from work for 14 days after the last exposure. And then if they develop fever or symptoms, they would be tested. For a low risk exposure, self-monitoring for 14 days and actually continuation of work. So no restriction from work, unless of course they develop fever or other symptoms, at which point they would be restricted and tested. So this has been the basic algorithm. And of course there are some variations on this depending on the county positivity rate and outbreaks. Next slide. As far as visitation goes, we're all very well aware of the isolation that has been a big concern in long-term care facilities. And we're going to talk about outdoor visitation in a moment. Indoor visitation right now, of course, being winter, although it's not so cold today, but in general, the cold prohibits as much outdoor visitation. So indoor visitation is permitted, but under very specific circumstances. So there needs to be low community spread, facility is outbreak free. There has to be a 14-day supply of PPE available and adequate staff to assist the visitors. And the way that the community spread is identified here is less than 25 cases per 100,000 would be considered low, and that would allow a facility to permit indoor visitation, given the other factors as well. If it's between 26 and 175, the visitor actually needs to present with a negative PCR that's been completed within 48 hours. As we all know, that can be tough if turnaround time is slow with the PCR test. And also this has to be arranged thoughtfully. So once you've got the test, you sort of have to swing into action to get the visit arranged. So these are the criteria for indoor visitation. It's been exceedingly difficult to meet these criteria for most facilities. Next slide. And then outdoor visitation. So you see here in this picture a pod and the bench where the family would sit here over to the left, and then the resident would be wheeled into the pod there. It would normally have plastic sheets across those areas, those frames there, but because it's winter, those are not currently up. But outdoor visitation is allowed with 8 or few visitors. The resident needs to be without COVID or active infection, and they need to not be on a transmission-based precaution plan. The facility needs to be without an active outbreak and be permitted within the statewide restrictions, and all these visits need to be scheduled and all visitors screened. So again, a lot of work, of course, going into the outdoor visitation, but certainly a possibility when facilities are in a low risk state. Next slide. And those were the main things we wanted to present to you today. And I'll go ahead and turn it back to you, Dr. Rowan.
Thank you so much. That was fantastic. I think we'll probably have a lot of discussion about that, but we'll go ahead and move into the next presentation first, and then we'll have discussion at the end. And as Victoria put in the chat, feel free to put questions in the chat or to send them to me or Victoria, or you can certainly hold on to them inside your head and ask them at the end. So next we're going to move on to our second presentation, which is by Dr. Carlos Franco Paredes. He is an associate professor of medicine in the Division of Infectious Disease at the University of Colorado. And he's also the associate, he's the fellowship program director, not the associate, the head honcho. So Dr. Franco Paredes will be talking about COVID management in correctional facilities in the United States.
Start video. Okay. Thank you, Sarah. Can you hear me okay?
Yes.
Okay, perfect. So let me move here. So what I'll do is I'll present you the experience that I observed or participated during the COVID-19 pandemic in correctional facilities. Initially, I started with immigration detention centers in collaboration with Michelle Haas, with Janine Young and the Human Rights Clinic at Denver Health. However, because of the pandemic, we began to realize that it was important to extend our efforts to correctional facilities, jails, and prisons. So I would like to start by talking about this quote from a book movie, which I think we're all connected, and it really, I became 50 years old this year, and maybe it just really hit me to understand that really, jails, prisons, detention centers are extensions of society, and that we are all bound by good and bad, but we're all bound, and we need to think about this. So one of these experiences in the first the initial inspection that I did in a local jail here in Colorado, one of the cellmates of one of the patients who died asked this question, and I talked about this before, and he's dying from COVID-19, part of the incarceration punishment. And when this gentleman asked this question, it became at least clear to in my perspective, that it was very revealing, this question, in my opinion, because it really talked about how once you are inside the walls of a correctional facility, you are highly vulnerable, particularly during a pandemic. So in fact, as we know, the COVID-19 pandemic has helped us to realize or to unveil the structural factors that lead to different health outcomes, and many of these among the invisible populations, individuals largely out of sight, in whom the health inequities and many remediable injustices are there. We can definitely do more to protect them. And we know that minorities, if you want to look at this from that perspective, African American community, Latino, American Indian, or Native American have had disproportionate impact of the pandemic in terms of cases, hospitalizations, and deaths, and it's been reviewed in different ways. If we, sorry, my mouse is very sensitive. If we take the angle of social justice and health inequity, health equity is a significant component of social justice. And the reason for this is not only to be healthy, but it's also well-being. And I think that's one thing that we tend to not necessarily ignore, but we think about medical outcomes or health outcomes as, treating, tuberculosis, treating HIV, hepatitis C, et cetera. And that's important, but it should not stop there. We should think about, well-being and the opportunity to achieve, and the capability perspective by, developmental economists that, like Amartya Sen talks about. So this is very important. Health equity is basically, or health inequities are unfair, unjust, and unavoidable difference in health outcomes. a big component of these outcomes is structural racism. And, some specific examples of structural racism include, racial residential segregation in the US, discriminatory incarceration or mass incarceration, and health care quality and access as a significant health inequality. We know that racial residential segregation plays a major role in mass incarceration, but if we talk about, health equity perspective, we know that, for example, the major point of entry or the major point of spread of HIV/AIDS in the 1980s, was the introduction of crack cocaine into the major inner cities in the US, with significant spikes associated with these. And this is, the concentration of poor health outcomes, poor social conditions, poor schooling, all goes back to the 1930s policies of redlining in the inner cities, along with the great migration from the south of, about 5 to 6 million people developing, or ending in developing, along with unemployment, these so-called ghettos or inner city populations or inner city neighborhoods. And even when you adjust for, socioeconomic factors, racism continues to provide a significant gap in the health of Black versus white people, as being studied in different ways. Sorry. So if we move now to talk about the criminal justice system and the COVID-19 pandemic, we know that it's not a coincidence that that the pandemic has hit significantly the correctional facilities, as predicted by ACLU, as predicted by correctional health experts and public health experts nationwide. And while many countries in the world have decided to do significant incarceration, countries like Iran reducing their populations to prevent some of these problems, the US reduced some, we'll talk about this in a second, only about 11% has reduced, but by the end of last year, there was a significant increase in the population again to increase levels almost back to pre-pandemic levels. And there's a continuing revolving door, particularly between county jails and community supervision, with many people, about 2.2 million people a year, which is about 25% of the world's incarcerated population. The demographics in correctional facilities, is well known. Obviously, may vary if you talk about federal state versus federal state prisons versus county jails. But overall, I think the risk in general is much higher for risk of imprisonment, Black men, followed by Latino, by Native Americans, and then white men. Again, this proportion may vary according to, for example, federal prisons may have a more homogeneous rates, but still predominantly Black and Latino men. These mass incarceration policies stem from many reasons, but some of them political, some of them policies of oppression in the 60s, 70s. And this high incarceration, again, has focused along with police or inhumane policing into specific neighborhoods. So with the COVID-19 pandemic, the perfect storm, came together behind the walls with, built environments that, are not designed, basically the antithesis of social distancing, overcrowding, poor sanitation, insufficient and timely medical care pre-pandemic, during the pandemic, along with factors such as accelerated aging. We know that people stay more than a year in a prison. Their aging is moving much faster, so there's a gap or dissociation between chronological age and biological age, or sometimes more than 10 years. And there's a high prevalence on underlying medical conditions like diabetes, hypertension, and so on. So if we look at the, this is sort of like an old slide now, but the first three waves, let's call them, or three waves of structural vulnerabilities, as our colleagues presented in nursing homes and long-term care facilities, was the major initial wave, followed by sustained community transmission in major cities. But there was, by the end of March, early April, the spread in carceral settings in many parts of the country. And as of now, if you look at the UCLA behind project behind the UCLA behind walls of the COVID-19 project, or the prison COVID-19 project, we see that about incarcerated individuals with COVID-19 as of yesterday, 317,000 cases with 1,881 deaths, and same, in a way, proportional correctional officers with 101 deaths. The state of Colorado, the Department of Corrections data as of today, they report 7,252 cases among 17,800 individuals with 25 deaths. What is interesting or unfortunate about these numbers is that just about 10 days ago, writing a letter regarding vaccination for incarcerated individuals in Colorado to the governor, these deaths were only at number 12 or 13. So its number continues to increase and is concerning. Overall, nationwide, which is the graph here by the UCLA Behind Bars group, it shows that the risk of becoming infected with COVID-19 is at least four times higher than the general population. If you look at these analysis that we made when we did it, it was like number of deaths about a month ago was close to the number of deaths by capital punishment in 44 years. This includes federal and state capital punishments. Now has extensively passed this number in just about a month from 1521 to 1881. And you can argue why to talk about this issue, but the social roots are related. There's no question about that. And this goes back to these structures of oppression in the U.S. And regarding the criminal justice system, there's no question that in a way it continues to be a sort of legal lynching. And this is the number that we talk about, the 11% population reduction that was estimated with including immigration detention centers. So correctional facilities to justify a lot of the public health, if you want to move away from doing the right thing, which is the moral and the human rights perspectives, from public health perspective too, these facilities become, not initially, it was more introduction by correctional officers, but as the pandemic spread throughout major cities, so inside the walls of these facilities, and the caseload, there's been this analysis by the Prison Policy Initiative that about 30% of cases, or let me say it differently, that there's been the contribution of correctional facilities as amplifiers of COVID-19 transmission have been documented in, at least in Cobb County Jail, 13% transmission back to the community for people that were released. And, these national or nationwide analysis show also that there's been, particularly with, growing incarceration or the growing number of patients, incarcerated individuals, the higher the transmission in some of these communities. So to finalize, one of the things that it's important to talk about is community reentry. And for this purpose, the only community reentry clinic in the state is in the Denver Health, directly with the Department of Corrections. But there's a need to pay more attention to this period because we know that the rate of recidivism is, above, close to 50%. So we have to think about the health of people once they're released. And this individual, just what are the chances of some of these guys that really want to have a better life, a better quality of, basically quality of life. What can we do? And there's no questions that, this short period, usually after release, there's increased high risk of dying from different reasons. But if we pay attention to these factors, I think from the health perspective or from our professional activities, we can contribute to our, colleagues in the community reentry groups to reduce some of the recidivism by promoting better health and trying to achieve wellness. And that's why, I think, the traditional model of care is that we basically work in this setting, and it's interesting and it's great and it's important. But it's important also to think about the community, and going to the community and address some of these factors is crucial. So to finalize the wish list, we have to transform the narrative. Unfortunately, jails, prisons, detention centers have become or have been major epicenters of COVID-19 transmission, deaths, and sadness, I would say. So improving the conditions to protect these highly vulnerable populations is crucial. Is in fact a constitutional mandate that is largely ignored by many. Reducing mass incarceration in the short and long term continues to be an important strategy by policies such as the war on drugs that have only destroyed families and individual lives. Inhumane policing, which is now part of the public health dialogue. Reducing structural racism, it's important to talk about these. And for example, the Colorado Criminal Coalition, Justice Reform Coalition, using their model as the transforming safety to shift funds from DOC to build community safety, may be the way to go, or it is the way to go. We just need to change minds and change narratives. And there's no question that this closure of immigration detention centers in discussions with, prominent people, professors here in Colorado, these are basically modern concentration camps that should finish. And it brings back echoes of the Holocaust that happened during the Second World War. So this is it. Thank you, Sarah, for the opportunity to present today.
Carlos, thank you so much for your presentation and your perspectives. I would like to point out that we do have 2 additional folks here who have agreed to be panelists after our final presentation. Dr. Peter Crum, who is the Correctional Care Medical Director with Denver Health and Hospital Authority, and also Dr. Sarah Stella, who is a hospitalist at Denver Health, who's a specialist in care for people experiencing homelessness. So I just wanted to mention that they're here. And with that, we'll turn it over to Dr. Ed Farrell, who is the Director of Integrated Health Services at the Colorado Coalition for the Homeless, and he'll be discussing COVID among people experiencing homelessness. And without delay, Dr. Farrell.
Hey, thank you so much, Dr. Rowan. As noted, I have the privilege of working at the Colorado Coalition for the Homeless. I'm kind of in my 19th year here. I had an 8-year hiatus a couple of years ago where I worked for a different FQ. I'll probably go pretty quickly through this. And I'd like to note that it's hard to follow Dr. Franco Paredes because that was outstanding. Really enjoyed that. I don't have any disclosures. Big gratitude that I'm here with you all. And I am trying to find gratitude in this time of COVIDity. And one gratitude I have is the ability to link and form partnerships with organizations and people that I never knew I would at the beginning of the year. We'll talk a little bit about the epidemiology, a little bit on isolation, quarantine, staff exposures. We've got to note what people experiencing homelessness already were facing. This was a picture I took on the way to work about 2 months ago. This is where folks are living on the streets of Denver. These people are at lower risk than the people in the shelters, as revealed by at least our testing. And this is the same population that Dr. Franco Paredes was talking about, that folks do cycle in and out of the jail, the hospitals, and the prisons, and social justice and structural racism are running amok, and we see it every day very soberingly. This is another view, just hard to imagine folks living in these conditions. And I'd like to note that this is one of my favorite slides in terms of phases of disaster, and I'd say the toughest 1 to 3 months are right now, and that people are facing the cold, the dark, the holidays, more people experiencing homelessness than ever, quadruple the generalized anxiety disorder and depression. We're fatigued with everything, and social injustice continues. Great slide from SAMHSA, referenced at the bottom of that slide. And we need to remember that the people that we journey with who are experiencing homelessness, really on this Maslow's hierarchy of needs, they are just about food, warmth, water, and rest. And some are up in this safety and security. Very few are up here. And they are easily, almost everybody I know, I'd say everyone I've ever met who's been facing homelessness has a trauma history that's very sobering that you do get to if you peel away the layers of the onion. If you don't know about this study on the ACEs score, adverse childhood experiences, there's a total dose relationship. That number of adverse childhood experiences, as it goes up, your risk of homelessness increases proportionally. And this is just what we need to remember as we meet people where they are. And for folks in our shelter, due to the injustices galore that and the blight that homelessness has honestly put upon our country for 35 or more years, it's pretty hard for them to follow the advice that I would give President Trump and President-elect Biden. Live like you and everyone else are contagious. Live so you never get defined as a close contact. Pretty tough to do if you're homeless. CCH's been around for a long time, 1984. I came on board in 90, do I remember? 1994. 2019, we served 13,000 folks, and at least 3,500 of those folks are at high risk. The only thing I'll note is that our obesity data came from whether or not providers wrote down the word obesity or high BMI in a chart. It's actually, that number is much higher. What we found from the beginning, nascent beginnings of COVID wreaking its havoc on the globe, especially here in the spring, that the community partnerships were key. Denver Joint Task Force was all these amazing public health organizations in the city and homeless shelters coming together in a rather magical way. We meet 2 to 5 times per week with remarkable collaborations to help out people experiencing homelessness. Thanks to Denver Health for this data. COVID hospitalizations among PEH. Bottom line is if you're homeless, you've got triple the risk of hospitalization. As Dr. Franco Paredes noted, and you're more likely to be a person of color if you're homeless, et cetera. And then there's endless reams of data, as Dr. Rowan knows. So I just had to do a snippet of something. And I used the ones from Denver Public Health here, the number of people tested and the positivity. We can see this big positivity back here in the spring. We were all breathing easier here. And then, we were all still kind of freaking out in November, but things weren't as bad as we thought. And then just recently, we had one of our shelters with a 36% positivity rate that we were all concerned about. Great news as hot off the presses from yesterday, 6:20 p.m. is when I think I got the email that is not the viral variant, with the higher transmissibility. One of our big responses, CCH, with our community cohorts was to establish protective action and activated respite. So PA, protective action, it was an effort to de-densify the shelters and move clients with high-risk conditions to motels. All along, us saying, why don't we just house people? Just gotta emphasize that. Currently, we have 700 clients in 6 area motels with high-risk conditions. Pretty amazing effort on just so many community partners. Then AR is activated respite, which is the language for using a local motel to isolate, sometimes quarantine, people with COVID-19 infection, and this indeed has also been a partnership. I did not show the data all the way back because it doesn't fit on one slide, but we were getting into activated respite, people with COVID who are homeless and can't isolate. So some people can't isolate with a family member on the streets. We peaked with 120 admissions per week in late April. And we were breathing a sigh of relief here, but concerned it could get worse at any minute. And then we were living in this mid-50s, and then everything kind of hit the fan again right around Christmas. I was working on Christmas Day at activated respite, and we had admitted, I think, 25 to 30 people from an Aurora shelter on the eve of Christmas Eve. So sobering times right now while we have the hope of the vaccine. Continuing on. And then the data is always so crucial. And this is our data on what our occupied rooms and activated respite are, with projection curves depending on how many more admits we get. So we all nerd out on this data on a daily basis, trying to prognosticate the future and be prepared. I'm gonna breeze through these, but I just wanna say that, I was asked to kind of go into what do you do with folks who need exposure and quarantine and isolation, who've been exposed, and we just need to nail these definitions. And this definition of the close contact did change from the CDC, back about a month and a half ago. And I'm going to just go through here that, the difference between I and Q. We aren't doing quarantine at activated respite because we couldn't handle the volume. I like mnemonics sometimes. Quarantine with the E at the end is for exposure. I is for isolation. For people who might sometimes think about scenarios, there's some nice ones at this website. And then just regarding, I really liked Carrie Levy's slide on the isolation of staff who've been exposed. I do think this is great. This is what we've followed with the advisement of wise infectious disease experts and partners at DPH. But look, if it's a household contact, near close contact, of course you're going to have to quarantine. But what we've done with people at work who become positive, who usually become positive from not a work exposure, it's usually their household member or unknown. We're all universally masking all the time, so we don't quarantine as long as we're abiding by that. And that's helped preserve workforce because, and we've taken the usual steps to really assure universal masking, don't be defined as a close contact. Our testing strategy has evolved from symptom-based at the very beginning to these remarkable surveillance testing efforts at shelters from DDPHE and Denver Public Health to adding on point of care testing. I wish I had easily been able to get this slide of our outdoor tents, but now we have this community room. A large space has been converted into a 12 exam room space with green, red, yellow zones, markings on, hey, this is for your doffing and donning, similar to what folks have been doing all over the country. I do not like busy slides. This is the second rule I'm going to not follow today. But this is our point of care virus antigen testing. If you have new symptoms and you can isolate, you don't have to go into AR. But if the point of care antigen testing, so we started this with backup of PCR. If they're not a repeat positive, we placed people in activated respite. And then for the point of care positives, we believed the result was backup with PCR, and those people get placed in the AR. If your point of care is negative, I think that's a clinical conundrum. If the patient has the big four symptoms, the original fever, cough, shortness of breath, loss of taste, smell, we might be saying this person might be a COVID PUI suspect, even if their PCR is negative. Likely will admit them, clinically complicated, seek clinical consultation. That's enough that I'll go into on that slide. And then we did run point of care accuracy testing on this Binax Now. I'm sorry that maybe data nerds will be glad to see this 2x2 table, but as I think Carrie mentioned earlier that it's or it might have been saying that specificity is quite good. If the test is negative, then we feel pretty good. Excuse me, if the test is positive, we feel pretty good about it. But but we still have this problem with the point of care can be can be negative and the PCR comes back positive. Sorry that I misspoke there for a second, but so, and then and remember the Binax is really only approved for people with symptoms. So we can kind of believe the positive test and act on it, but the negative test, tenga cuidado, be careful, it might not be accurate. And I'm going to close with, of all forms of inequality, injustice in healthcare, this is the most shocking and inhumane. And it's mind-boggling how we see that every day in the folks who experience homelessness. Everything is subject to change. And I still think there's hope on the horizon, including with the vaccine.
Ed, is that you?
That's it.
Is that your silhouette in front of the ocean?
Oh, no, it isn't. All of us.
Thank you very much to all of our presenters. And I would like to offer Dr. Crum a chance to just offer some comments if you have any. Pete, if you're here, and if not, did I just log out? No, okay. And if not, we can open up to questions. But Dr. Crum, did you want to say anything? Actually, is he still here? Oh yeah, you're here. You are on mute if you're trying to speak. Okay. I'm gonna then open it up to questions. Does anyone have any questions for our presenters? And Dr. Stella, same, if you wanted to jump in and offer any additional comments, please do.
Unmute. Can you hear me now, Sarah?
I can, yes, thank you.
Sorry about that.
Because I couldn't see your face.
I've got a landline, a cell phone, and the computer on, and I'm trying to figure out which buttons to push. So, am I still there?
You're still here, and you'll
Okay.
have it totally figured out by the next pandemic.
Yeah. Oh gosh, don't even say that. Well, I was like I was talking into the phone that was muted. I don't have anything prepared. I think that was fantastic. Both the last two presenters, Dr. Farrell, I think, I don't know that we've ever met, but I think we share quite a few patients and have been working kind of parallel to one another to get our patients taken care of, at least for hours once they leave our facility. I think that I can't really add much to your presentation. That was fantastic. I wish I had all of your slides. But it has been a challenge, of course. I think that with our facilities here, the Denver jail system, the Denver Sheriff's Department, our overall bottom line, and I think I saw this in somebody's write-up in the last few weeks, was population is key for us in an enclosed facility like this, just like I'm sure it is in nursing homes as well. I think once you can get your populations under control, meaning as low as possible, then you have the opportunity to work with your, well, our mantra is down isolation. Once we can down isolate into quarantining and isolating positive inmates, then we can work a lot better on preventing explosions of the infection that are seen all over the place. And I think that with us, as Dr. Farrell was saying, it's a cooperation with multiple players involved, the judicial system, with not just the courts, but also the city council, with the police department, with the sheriffs, with folks like Dr. Farrell's group, Colorado Coalition, so that we can do discharge planning with our inmates. But I think that we have found that the more people that we bring in to help, and there's always people willing to help, to get these people situated, whether it's before incarceration, during incarceration, or after incarceration, that's the most important. And there are plenty of people out there who are willing to help these folks as we just saw on those two last presentations. But again, I could go on with that all day thanking people, but if there's any specific questions, I'm happy to answer them. Once again, thanks for both of those last two presentations. That was wonderful.
And Sarah, did you want to add any comments before we get into questions?
Yeah, I will just kind of add to what Dr. Farrell said about, community partnerships being so key to meeting the needs of our vulnerable populations, including especially those experiencing homelessness. And I do sit on the Denver Joint Task Force with Dr. Rowan and Dr. Farrell, and that's been just sort of my silver lining in COVID, so to speak, if there is one, is we were fortunate enough to have pre-existing relationships with the Colorado Coalition for the Homeless, which really allowed us to be nimble and to really rapidly figure out like what our priorities were, what our strategy was going to be based on the experience of other cities who were a few weeks ahead of us in the curve. And so I think it's always that good advice of you never want to be handing out your business card in the middle of a pandemic. It's very helpful to know the people in your community and to have relationships with them. And that has been key for us in the response among people experiencing homelessness. The other thing I will point out is that I'm a hospitalist. I really care about, I was seeing, I had one foot in the hospital, seeing like the dire situation of what was happening in the hospital and the capacity issues, and growing very concerned about that. And part of the isolation resources that Dr. Farrell mentioned for activated respite, part of that was about, decreasing transmission, pulling people out of the congregate settings. And then part of that was also about decreasing hospital overload. And that did allow us during our surge in the spring to prevent Denver Health from becoming, could have been a lot worse. And so I was very fortunate to see the work that was going on in the community to provide an alternative for patients rather than going to the ED or the hospital, and then allowing our hospital to decompress on the back end to allow patients to go into activated respite and have a place to continue to recover that was not the hospital.
Thanks, Sarah. I have a couple questions. One came to us from Jackie, and I don't know if she wants to unmute, but it was about COVID among women who are incarcerated. I'm not sure if she's still on. But if either of Dr. Franco-Paredes or Dr. Crum wanted to comment on what you're seeing about rates of COVID among incarcerated women.
Thank you, Sarah. I would say that I'm not a correctional officer or correctional health expert by any means, and I will, would rely on what Dr. Crum or Sarah may have to say too. But, it seems to me that, I had just give you my perspective is that among the, I participate in about 11 different settings doing inspections with ACLU or related NGOs in jails, prisons with outbreaks. And what is interesting though, it may have to do with the proportion. I don't know the exact proportion, but there's definitely more men than women in these settings. And my recollection of these inspections and looking at the outbreaks is that the number of cases has been very, very small compared to men.
I can add to that. Was the specific question, what are the rates that we're seeing?
This is Jack.
Oh yeah, go ahead, Jackie, thanks.
Yeah, mine was in relation. I noticed, the 1 to 17, 1 to 6, and the 1 to 3 for the 3 groups of the racial discrepancy. I was just curious, do we have numbers on the females as well?
We don't keep the stats for the male versus female in the Denver Sheriff's Department. I can tell you that because of our housing, again, it all comes down to population, and because mainly our women inmates are housed out at our county facility, there's much more room for them for down isolating, so we don't have the subsequent post arrest or incarceration problems with exposure in open pods with our female inmates. So it's a lot lower. I can't tell you how much it is lower, but I can only tell you that's how it works in our facility. I'm sure it's different in every facility. So that's all I can. That's really all I can add to that from my point of view.
Yeah, I would ask Dr. Farrell or Dr. Stella to comment on rates of COVID that we've seen among women experiencing homelessness. It's been interesting to see that the rates have been significantly lower, but how much of that is a product of just sort of the same issue of variable prevalence. And then in something like a long-term care facility where you don't have so much of a disparity in terms of the population, I'm wondering what you all are seeing in terms of gender disparities of COVID.
Sarah, do you have that latest data on the tip of your tongue? I don't have it on the tip of my tongue, but it is lower among women. And I do think that the percentage of men in our shelters is higher. And it does seem that, oftentimes we are able to get women into alternative living arrangements rather than the congregate shelters. So for instance, the VOA shelter, is actually people kind of have their own rooms, family, et cetera. I don't know if you have anything to add on that, Sarah.
And this is Singh. I likewise don't have any data from nursing homes, but it is very interesting that long-term care facilities, majority are actually women. And so it turns out that the men have actually a more of a chance, kind of the opposite situation of maybe not having a roommate, of possibly, being a little bit more isolated compared to the women. So you'd almost think that our data would be the opposite of what you're seeing in the incarcerated and homeless settings.
Yeah, I'm sort of curious to know, where the population is different, what the rates are like. I'm sure we can find that data. Anyone else with any questions for our panelists or our presenters? And Victoria's just put a link to our SurveyMonkey. With, almost probably like 1 minute to go, I wonder about the long-term care facilities, if you all have started vaccinating yet.
We have the partnership with the long-term care for pharmacies started December 28th. Several facilities have started their vaccination. We're hoping to get more. I think that the federal goal is to have all the facilities vaccinated by March. I would like to see a much faster timeline than that. We can't afford to keep waiting, but I got mine last week at the building. It was a great learning experience, just trying to vaccinate a bunch of people at one time. But yes, starting.
That's awesome. All right. Well, I think we're at time. Victoria, any last comments?
Just a reminder, the recording will be uploaded. You will all get the survey link and the link to the website, just again, in case you missed it in the chat, but it'll be emailed to you all by the end of the day, along with all those resources. And please reach out if you have any questions or anything. Our next session will be January 19th, which will be our last session, sadly, but it will be on vaccine follow-up. So make sure to come back for that one, as it'll be another great discussion with more experts.
And hopefully we'll all be able to share more experience by then. Thank you guys so much, and we'll see you in 2 weeks.